being here this evening, and I want to thank Dr. Nahara for inviting me to give this talk. My name is David W. Richards, and I'm on the faculty of the USF Department of Ophthalmology, where I've been for many years now. I also do research in physics and astronomy. That's why I have these extra things on here. In fact, my appointment in ophthalmology is only 70%. The rest of the time I do other stuff, and we'll spend 1% of the talk on that at the end. In the meantime, we'll talk about glaucoma, which is my specialty, and we're going to talk a little bit about the epidemiology of the disease, pathophysiology, the treatment, and I guess in simple terms, we're going to talk about what it is, how it's diagnosed, and how it's treated. We won't spend a lot of time on treatment because that's really a whole another lecture. And I think it's more important to spread the word of what glaucoma is and why it's important to pay attention, because it's not a disease that really gets a lot of publicity compared to some others these days. Glaucoma is a potentially blinding disease, usually caused by elevated pressure in the eye, and interestingly, it's the second most common cause of irreversible blindness in this country after macular degeneration. And believe it or not, around the world, it is the most common cause of irreversible blindness. Cataract is much more common, but that's potentially reversible. Other diseases that affect the cornea, for example, like vitamin A deficiency, is potentially reversible. But glaucoma is irreversible because it destroys the optic nerve permanently. And that's why it needs to be detected and treated. This is a picture of what we call the visual field. This is a map made on a machine that we'll talk about a lot tonight, where the patient looks at the center of a target and the computer maps out the peripheral vision. This is a normal visual field test. This is the blind spot, which corresponds to the point in the visual field where the optic nerve attaches to the back of the eye. And there are no photoreceptors there, so that's why the blind spot appears. What happens in glaucoma is that the peripheral vision starts to be destroyed, and gradually that destructive process moves in towards the center. So this is someone with relatively advanced glaucoma. This is the center of vision. This is the blind spot. This is the upper part of the visual field. This is the lower part. This is the side towards the nose. So this is the way the right eye sees the world in that patient. And in the upper part of the vision over towards the nose, that patient can't see anymore. And that's why this is showing up as black or dark gray. The straight ahead vision right here could still be a perfect 20/20 without glasses. And this is why this patient could have the disease, and a lot of people do, that don't even know it, because their peripheral vision is gradually vanishing, disappearing, yet they see perfectly straight ahead. They can go in and take their driver's license test, for example, and pass with no glasses, no problem. Yet, if both eyes have damage like this, they shouldn't be driving, because they won't see that kid stepping off the curb, they won't see that car in the other lane. And that's another problem. It's a medical legal problem. The people out there driving who shouldn't be driving, and this, to my knowledge, has never even been investigated. Maybe we should do that as a research study. Go to people who've had car accidents and test their side vision. Never been done to my knowledge. So here's somebody with the left eye visual field where the peripheral vision damage has moved in towards the center and may or may not have knocked out the center of vision. This is the other eye with early damage. These computer programs produce all sorts of plots that present the data in different ways. One of the problems we have is that the spaces between these spots are such that there could still be central vision here, but it's not even detected by the machine. But in any event, this patient is in great danger, and if the pressure is not brought down, this eye is going to basically go blind very soon. This is a series of visual fields showing the progression. It's not clear enough to see the dates on here, but this is what can happen in an untreated eye with glaucoma. Virtually no damage, moderate damage, and severe damage. And the time scale of this is usually a period of years. And for that reason, glaucoma is a lot like diabetes. It can be very, very slowly progressive. And if you don't control the pressure in the eye, just like you control the blood sugar in a diabetic, the damage will slowly creep along. In the diabetic, the kidneys or the heart or the vasculature will be damaged. Well, in glaucoma, it's the optic nerve and peripheral vision. We'll talk more about the optic nerves as we go along. Now, this is a picture of the visual fields of someone with a tumor of the pituitary gland, and they have a so-called bitemporal hemianopsia. This is different from glaucoma. And Dr. Naha will remember back when he studied visual fields that all sorts of things can show on the visual fields which are not glaucoma, all sorts of neurological diseases. So we use this type of testing for many other purposes. But the pattern of visual field loss in glaucoma is fairly typical. And you can see, for example, in this one, the damage is limited to below the horizontal meridian in one quadrant, whereas in this neurological disease, it respects the vertical. That's a typical sign of neurological disease. It respects the vertical as opposed to respecting the horizontal like it does here. And we often get patients in our clinic that visual field is done thinking the patient has glaucoma and some sort of neurological disease pops up. So we can make a contribution to diagnosis of other diseases as long as we know what we're doing with these tests. Okay, how is glaucoma diagnosed? This is another whole lecture in itself because the very simplistic point of view is that the eye pressure is too high and therefore the patient has glaucoma and he has to take drops and end of story. The problem is what is high for one patient may not be high for the other patient, and what the pressure that's low enough for one patient may not be low enough for the other patient. And the treatment has to be individualized. Just like we were talking about psychiatry, you can't just put everybody in the same box. You have to customize the diagnosis and customize the treatment for each individual. So I don't participate, for example, in screening for glaucoma at the shopping mall or at the local church, because if you just measure somebody's eye pressure, it may come out in statistically to be normal, and that patient may in fact have glaucoma and you're missing it. So you have a false negative. Then you have other people where the pressure might be slightly above normal, and you panic and the patient panics, and it's a false positive because everybody has a different range of pressure to which they're sensitive. So what do you have to do? Well, you have to do a complete eye exam. You have to get the intraocular pressure, do your exam, and look at the optic nerve and put the pieces together. And we have a huge category of patients we call glaucoma suspects. And these are probably the most common cause of a referral over to my clinic is somebody on the outside, an optometrist or other ophthalmologist says, I think he might have glaucoma. Go in and get checked out. And some do and some don't. Some have to be followed, some have to be treated. But you have to do a complete exam. Okay, suppose you make the diagnosis, well then you have 4 levels of treatment. Drops, lasers, oral medications, and surgery. And surgery for glaucoma is very risky surgery. So we try to control people as long as we can on drops and with lasers. Oral medications we don't use too much because they have a lot of side effects. So early glaucoma you want to treat with drops, maybe laser. Try to avoid getting into this region because the perfect glaucoma surgery doesn't exist. It's not like cataract surgery these days, which has been improved to a very high level of quality. glaucoma surgery at that level doesn't exist. So we like to avoid it. On the other hand, in some cases we don't have a choice. Everything else has failed and we have to go on to surgery. Okay, what is the cause of glaucoma? Well, interestingly, the exact cause in most cases is not known. Something goes wrong with the fluid drainage from the eye, but at the histologic or cellular level, we don't actually know what's going on. This is an area where a lot of research has been done and more needs to be done. Another thing that surprises people that it's not just older people who get it. It can affect any age group, including babies and teenagers and children. So we don't have, lacking a very good screening method, there are going to be babies and kids and teenagers and adults, every age range is a potential glaucoma case. Finally, there's no cure, but it is controllable in most cases. This is a baby with primary congenital glaucoma at a very severe level where the eye pressure is so high that the corneas have become hydrated with fluid from inside the eye being pushed into the cornea, and they've become opaque. So this is a dangerous disease that can affect any age. Well, before we talk more about glaucoma in detail, we'll do spend a little bit of time on vision, because that's another great unknown. How do we see? Nobody really knows. And you'd think with all these advances in technology and DNA and everything, somebody would have an explanation of how we see, and it doesn't exist. One of the problems with vision is, linked with the problem of human consciousness, which we don't understand either. And then all of you people who work in psychiatry know how difficult it is to understand how people think. Schrödinger, one of the great physicists of the 20th century, was interested in this problem, and he said consciousness may never be understood. And it's certainly, almost 100 years since he said that, it's still not understood. So the clinician in my specialty is more like an engineer or a technician. We're trying to fix a defective biological system, even though we don't really understand exactly how it works. And that's one of the challenges. How to repair a malfunctioning biomechanical system, such as an eye with glaucoma. Hasn't been solved. That's Schrödinger. And that's Schrödinger's equation. What is this? Describes every particle in nature. Every electron, proton, neutron, photon obeys his equation, which basically just says this is the wave function. It's a particle or a wave. So this is the waviness of an electron. The energy of that is related to the time derivative, or the wiggliness of that wave. And if we could only derive everything we needed to know from that, that's the hard part. That's the equation, but deriving things from it is not easy. But this governs the light coming in the eye. It governs the photoreceptors in the back of the eye and the production of neurological signals that go through the optic nerve to the brain. So there's a physics basis to all this. As I was saying before, that's a little bit repetitive. We don't know exactly how we see. Now, the other physical principle that governs light is the quantum nature of light. So that's Max Planck. And that's even a simpler equation. Remember, the energy of a photon is equal to a constant times the photon frequency. So higher frequency, higher energy. Higher frequency means a bluer color, lower frequency means a redder color. Why is that important? Because we see in a range of wavelengths from the red on the long wavelength side to the blue on the short wavelength side. And one of my favorite questions to our residents is, why do we see in that range of wavelengths? And of course, they went through medical school and college and never thought about it. And there's a very simple explanation for that. This is the spectrum of the sun's radiation. Okay, this is energy, and this is wavelength. Okay, long wavelength, short wavelength, high energy, low energy. This is where the visible spectrum is located, right at the peak of the solar spectrum. So since we're products of evolution over millions of years or billions of years, nature took advantage of the maximum amount of light that was available so that our eyes would detect light in that range. And then through other magic that we don't understand, the brain divides that up into the colors of the spectrum. Now, if you were an eagle, you would see further into the ultraviolet. So your homework is, what color does the eagle see over here? We have no idea, because we can't even imagine other colors outside the range that we're familiar with. If you're a mosquito, you see in the, well, this would be the infrared. This is the mosquito, this is the eagle. What color does the mosquito see when he's about to bite you? Nobody knows, because we can't even visualize colors outside the range that we're familiar with. But there are animals out there that see those colors. I wish we had a way to see what they're seeing, because that would be an amazing thing, but we can't even imagine it. So anyway, this is why we see in the range that we see. It's an evolutionary result. By the way, the sun has been basically unchanged for the last couple of billion years. So this spectrum has been pretty much constant. There's been plenty of time for us to adjust. Now, there's a lot of talk about life on other worlds. So somebody on a planet rotating around the distant star that has a different spectrum is going to see probably in a different wavelength. We never see that on Star Trek or Star Wars. You know, everybody basically speaks American English and they look like us, these foreign aliens. But some other planet they may see in this spectral range, so the things that we normally see would be invisible to them. And the things that they see would be invisible to us. Okay, back to the eye. The eye is an optical system. You have the cornea, the lens, and the retina. And the purpose of the optical structures is to focus light on the retina. I tell my patients the eye is like a camera. You know, the signal hitting the retina is not where you see it. This is like the film, or you might say the sensor in your cell phone camera. And this is the cable that's sending that signal, the optic nerve, back to the brain. So the eye is the camera. The brain is the computer, and the optic nerve connects the two together. And glaucoma is bad because it destroys the optic nerve. And why does it destroy it, or how? We don't really know exactly. But the pressure, in most cases, is the cause of the damage, but the details of that mechanism are not understood. Now, you have the optic nerves. This is a 45-degree view of the brain. The eyes in front, the optic nerves cross here in what's called the optic chiasm, and then there's signals going to the left and the right through the so-called optic radiations. And way back here in the visual cortex of the occipital lobe is where you see. How that works, we don't know. But this is why somebody could be kicked in the back of the head by a horse and go blind, because the occipital lobes or the visual cortex has been damaged, or have a stroke affecting this region of the brain. So we as ophthalmologists examine the eyes and they look perfectly normal. The lens, the cornea, the optic nerve, the retina looks perfect, and the damage is back here. So we have a great fear of what's called an occipital lobe stroke, because that patient comes to us, can't see, and we can't do anything to help the patient, because the computer is damaged, the brain is damaged. This is another view. left eye, right eye, optic nerves, optic chiasm, optic radiations, visual cortex. And the pituitary gland is right here. This is why pituitary tumors can do a lot of damage, because the pituitary swells up, it pushes on the optic nerves, and of course there's plenty of places strokes can affect vision, all the way from the eye all the way back to the occipital lobes. Okay, statistics. Roughly half the people with the glaucoma in the U.S. are unaware they have the disease, since it is usually asymptomatic, and central vision is usually good until late in the disease. So there are people walking around out there right now, thousands and thousands of people, even in this supposedly advanced country that we have, that have glaucoma and don't know it. And in other countries, it's even worse. I don't know how many times I've had cases where somebody went in for a pair of glasses in his early 40s because he couldn't read, and boom, glaucoma. And some of those are bad because the pressure, normal pressure being 10 to 20, and they go in and they get a pair of glasses, and the optometrist checks the patient and the pressure is 30 or 35, and they have been sitting there for years and the patient didn't know it. Okay, what does it do? It causes atrophy of the optic nerve, usually elevated pressure, and the cause of the atrophy is maybe due to mechanical effects of pressure, or by interference with blood flow, or by something else. Tragically, the damage, once it occurs, is permanent. There's no way to fix the damage. And one of our gripes in a referral center like USF is the doctor on the outside waits. The vision is almost totally gone, and then they refer the patient in for us to fix it. And we can't fix it. So the treatment has to be initiated in advance, or based on judgment, you have to get more aggressive with the treatment before further damage is done. Okay, the most common type of glaucoma in this country is called chronic open angle, COAG, and there's usually elevated pressure, and again, the exact reason for the pressure elevation is unknown, just like most people with high blood pressure. We don't know exactly why the pressure is up. Glaucoma is similar in that sense. Now in Asia, there's a type of glaucoma that's very common called narrow angle or angle closure glaucoma, which is a little bit different. We'll talk about that a little bit more later. Okay, here's somebody having an intraocular pressure measurement done. This is the patient, this is the technician or the doctor, and what's going on here is this little Teflon device illuminated with a blue light is going to touch the eye and put a little pressure on the cornea to the point where it flattens the cornea, and that's all calibrated so that at a certain point the doctor or the technician can read off the pressure on a dial, which is down here somewhere. Here's the dial down here, and there's somewhere you read that number off. You don't see it in this slide. So this little device, when you go in to get your eye checked and they put in some numbing drops, is actually touching the eye and flattening the surface. This is called applanation tonometry, and this is the most accurate method we currently have for measuring pressure. Some optometrists will measure pressure by bouncing air off the cornea. They call that the air puff method, but it's not as accurate as actually touching the eye and flattening the cornea. This is what the doctor sees when he or she is measuring your pressure. Okay, the doctor's looking through here and sees this image of green circles. And when these circles are aligned in this way, they can read the pressure off. What's actually happening is these circles, this is fluorescein stain on the eye, are measuring the outer edges of this circular device, and there's a prism built in to split that outer edge, outer circle in half in such a way that when the pressures are balanced, the circles have exactly this size. And this is a fun question for the residents in ophthalmology. When I used to do their oral exams, I would ask them, what is this? And they usually don't know. Because they come in, they go through their training, they do this thing 100 times a week, and they don't even know how it works. That's why it's nice to have a physics background, because you can really find questions that are hard to answer for doctors of medicine. Okay, what about treatment? The only known treatment for glaucoma is to lower the pressure in the eye. It doesn't matter what the cause of that pressure is. The only way to prevent further damage that we know of is to lower the eye pressure. And there have been lots of studies over the years of different drugs. This drug or that drug protects the optic nerve or this or that, and nothing has ever been shown to work. So a lot of research has to be done. But right now, a patient comes in to see me or one of my glaucoma specialist colleagues, we have to get the pressure down if we're convinced that damage is ongoing. But here's the trouble you get into. How low is low enough for a given patient? Everybody's different. Somebody, let's say the normal pressure is 10 to 20, somebody might be safe at 15, somebody else at 19, somebody else might need a pressure of 8 to 10. And you know, nobody's born with a sign on his forehead saying, I need an eye pressure of so-and-so. You have to find that out by following the patient, looking at the optic nerve, doing the field tests over and over again. So the first problem is to find out the safe pressure for each patient, and that takes a lot of work. Should we just lower the pressure to 0 in everybody? No, because the pressure too low, then the eye doesn't work anymore. It's like you go and let the air out of the tires on your car. At a certain point, the tire's not going to work anymore. Well, the eye's the same. It has to have a certain pressure to function. Why not just do surgery on everybody and forget about drops and lasers and pills, lower the pressure surgically? Problem is, the perfect glaucoma surgery, or any surgery in my opinion, does not exist. And the complications of glaucoma surgery, that's about a 2-hour lecture. When I give that to the residents, it takes me 2 lectures to get through all the complications. And that's why a lot of our residents don't pick glaucoma, because it's too much work. You just have to be ready and able to deal with this endless list of complications. One of them being pressure too low. You know, your surgery went beautiful, everything went fine, and you're all done, and the next day the pressure's too low. How are you going to get the pressure up? Well, sometimes you have to go back to surgery to raise the pressure, and then it may be too high. So as I tell people, as walking, you know, getting on the top of a fence, you don't want to fall off on the high side or the low side. You have to keep your balance. And in very advanced cases, okay, you want to get that pressure down so low that it's just about sort of skimming along the hypotenuse level to save the eye. Because if you don't do that, they're going to lose. And then, speculatively speaking, there may be people that you can't get it low enough in the sense that it's, or low enough to protect from glaucoma might be too low to allow the eye to function properly. There are probably some people in that category that you drive it low with surgery to a level that's safe for the optic nerve, but then the eye starts to lose vision from low pressure. Those are nightmares. And it's another reason they don't like to go into this specialty. Okay, here is a picture. This is interesting. This is from Michigan, where Dr. Nakata used to be on faculty, he was telling me. There's a big eye center in Michigan, of course, University of Michigan. This is a normal fundus photo. In other words, if you look at somebody's eye and you look in the back with magnification, this is the retina, so this is the film in the camera, all this orange stuff. And this is the optic nerve, and this is the dark red vessels are the veins, and the skinnier vessels are the arteries. So the central retinal artery comes in along with the nerve and fans out, because all those photoreceptors in the retina need to get their blood supply. And then the blood goes through the capillaries and has to go back through the venous system. Then this is the so-called macula, which is the central part of the retina where you have your sharp vision for reading. And the very center of that is called the fovea. And this looks darker because the layers of the retina are thinnest right here. Why is that? Well, one reason is you have fewer layers of the retina blocking the flow of photons to the central part of the retina. That helps you see because there's less interference. Secondly, the nerve fibers, which fan out from the nerve to feed the retina, basically all end right here. The greatest number of fibers. So there are about 1.2 million nerve fibers that collect into this space to form the nerve. And the nerve is about 1.2 millimeters in diameter, so that's about a 16th of an inch. So this is highly magnified. And this is why we can't transplant an eye, because I have nightmares about this fairly frequently. You know, I accidentally took somebody's eye out during surgery. I had one about last week, and the other doctor said, just stick it back in and it'll grow back together. That's not going to happen, because you've got over 1 million fibers that all have to be connected up end to end to work. So that doesn't happen. It's probably never going to happen, at least for centuries before that can be done surgically. Okay, so this is a fairly normal looking retina, but if you look at the optic nerve, it has a very pale color. Now in this image, I'm not sure if it's pale because this is overexposed or it's pale because it's damaged. So we're going to look at some more nerves to talk about them. This is a more magnified view of an optic nerve, and this is probably normal. And you see the outer rim of the nerve is sort of pink, and the central part is sort of yellow. The normal nerve is like a donut, and the nerve fibers coming in create the donut part of the donut, and any leftover space is like the hole in the donut, and this is called the optic cup. And what we measure clinically is this diameter compared to this diameter, and that's called the cup diameter, disc diameter, the cup disc ratio. And what happens in glaucoma is the hole in the donut gets bigger and bigger and bigger till the donut disappears, because those nerve fibers are dying off and undergoing atrophy, and pretty soon there are no nerve fibers left, and all you have of the donut is the hole in the donut, and the donut is gone. Here's an example. Now this, not having stereo, this isn't very good, but here's the normal rim of the nerve in this eye, and the normal nerve tissue is all gone over in here. So the hole in the donut has extended over to this edge of the nerve. It's like somebody's been munching on one side of that donut, and only this part of the donut is left. So this is a fairly advanced damage in this case. Seen from the side, the hole in the donut corresponds to the deepening of the central part of the nerve. So here the nerve is being seen from the side, it's been chopped off. Here's a normal optic cup. With glaucoma, that cup is getting deeper, and very advanced glaucoma, it's very, very deep, like this. This is what they call a bean pot cup of the nerve. You know, a bean pot in Boston or something comes down and goes like this. And that's what happens to the optic nerve. You get atrophy, which changes the shape. And there are very few optic nerve diseases that cause cupping. There are many diseases that cause pallor, but not cupping. So this is usually an indicator when you see this cupping effect that glaucoma is present. So remember the anatomy of the retina when you studied anatomy. The light's coming in here, and you have all these retinal layers. Here are the photoreceptors that are picking up the photons, and then they send the signal backwards up through these other layers of the retina up to the nerve fiber layer, and the nerve fiber layer is connected to the nerve. So the light goes in this way, hits the rods and cones, and then the signal goes back out here, and all these cells in between the photoreceptors and the nerve fiber are like a mini computer. And those cells are processing the signals to look for things like different sizes of objects, different shapes of objects, and they're passing that along to the brain. So that by the time that message gets to the brain, there's already a lot of information in there the colors, the shapes, movements, stuff like that. And it's like a custom-built computer to process those signals. Well, in glaucoma, for some reason we don't understand, this layer is destroyed and this layer is destroyed. But there doesn't seem to be any damage to the so-called bipolar and horizontal cells or to the photoreceptors. But the ganglion cells, which are the cells connected to the nerve fiber layer, they're destroyed, then that message doesn't get out from the retina to make its way back to the brain anymore. And one of the things we're working on at USF in the physics department is trying to actually count the ganglion cells using what's called adaptive optics and what's called holographic imaging to try to image the human retina so you can count these cells in vivo. The glaucoma patient would come in and you do his ganglion cell count from one day to the next, and if you see these cells disappearing, you know the disease is progressing. If that ever worked, it would replace the visual field testing, because instead of having those very crude maps, you would actually be able to count millions of cells one by one and see if they're surviving or not. Okay, glaucoma can't be cured, we talked about that. Eye transplant can't be done, we talked about that. And we talked about lowering pressure to try to freeze damage. And how do we know that existing damage is stable? Well, that's one of the problems. We talked about cup disc ratio as a measure. This is very common, but it's very crude. A couple more examples. Here's one of the difficult cases. This is a nerve that is pale. You don't see much of a pink rim. Actually, the border of the nerve is here. And this structure surrounding the nerve is not part of the nerve, but it's a similar color. This is called a scleral crescent or peripapillary atrophy, which can be seen in some people. So this is one of the many problems the clinician has. Where does the nerve begin and end? And is that pallor of the nerve due to glaucoma damage or something else? So we spend a lot of time studying the optic nerve to try to decide whether it has damage, whether it's glaucomatous or not, and if not, what is it? There's another picture of a more normal nerve. So what you have to do in my specialty is just look at thousands of these nerves so you can take a quick look on the next patient and all that information is stored and you make a pretty good judgment call whether it's normal or not. Oh, here's another interesting case. This is a nerve where the donut looks very thin and the hole in the donut looks big. But this may not be abnormal. Just like we were saying, the pressure level can be variable from one patient to another. The geometry of the optic nerve can be variable from one patient to another. So this patient, for example, even though the cupping looks large and the diameter of the cup looks large, still could be normal. And that's another thing we get referrals for. Is that nerve normal or abnormal? And if not, why not? And that leads to more head scratching. Why can a nerve have this shape and still be normal? Well, you just think of all these nerve fibers from the retina have to feed together to form the optic nerve and go backwards out of the eye. If the scleral canal is of a larger diameter, there's a lot more room for the nerve fibers to get through and to exit the eye. And there's going to be a lot more leftover space once they do that. So we have to pay attention to what's the physical diameter of the nerve in millimeters. And we can measure that in cases where we're not sure what's going on. And if the physical diameter in millimeters is large, we know that this cupping is not pathological. It's just a normal variant. Okay, cup disc ratio can fool you, as I said, due to the variation of disc diameter. A normal nerve may have a large cup disc, and a damaged nerve may have a small cup disc. So that's one of the many variables we have to deal with. There's a normal one again. Okay, let's go back to the field test we talked a little bit about at the beginning, where we create those maps showing shadows in your vision. It's the gold standard, but it has a big problem. It's a subjective test. The way that mapping is done is the patient sits down at a machine and presses a button when little lights come on and off. So if the patient is falling asleep, it's not a good test. If the patient is nervous and excited, the patient pushes the button too much, and it's a bad test. So that's what we call a subjective test, because it depends on the cooperation of the patient. In fact, some people can't do that test at all. So then we have another problem, how to decide whether the disease is progressing. This is what a visual field machine looks like. The patient sits here, the technician sits over here. This girl puts her forehead up on this bar and looks at a target in the back of that dome, and there's computer-controlled presentation of dots, and she's supposed to be holding a button to press it when the lights come on and off. This takes about 5 minutes per eye, and it's very, very boring, which is another issue. But we do lots of these, hundreds of them every week, trying to track glaucoma, and we get these results that we talked about at the beginning. Here's somebody with moderate damage. Here's the center of vision, which may be good, but this damage across the top sort of follows the nerve fibers from the optic nerve out to the nasal quadrants, and there's damage there. And then there's a whole bunch of other numbers on here that present data that help us decide what's going on. Here's another one where the eye is almost normal. So we look at these quickly and say, well, that's damage, but the problem is to decide whether that damaged area is the same, better, or worse since last year or 6 months ago. And that's not a perfect science either, and that's one of my own areas of research interest, how to decide whether one of these fields is getting worse or not. We don't have the perfect way to analyze that. Okay, now one of the research areas that's going on is what's called optical coherence tomography. This is like a laser beam that is bounced off the back of the eye and creates maps of the thickness of the retina. And we use that quite a bit now. Here's an optic nerve, and the laser beam has drawn a circle around the nerve and compared the thickness of the retina to normals, which are stored in memory. So, for example, this would be the right eye, and this is this circle around the nerve unrolled from temporal to superior to nasal to inferior back to temporal. And the black line is the patient, green is normal, and red is abnormal. So this is saying the nerve fiber layer is thin down here in the inferotemporal region, which is also shown here. So this is a way to evaluate damage to the nerve fiber layer and the optic nerve, but it hasn't replaced field tests, and one of the reasons is there's a lot of variability in this type of testing, but it's helpful. Some people, you can see these red areas on the optic nerve, and the visual field test will be normal. Other people, the visual field test will be abnormal, and one of these things will be completely green. So they don't match up completely, but it's helpful. Okay, let's talk a little bit about what I call glaucoma plumbing, and that's related to this question of why is the pressure elevated? You know, the eye has to have clear fluid circulating at all times because you can't supply the cells in the eye with blood. You know, if there were blood in there, you couldn't see. So you have to have a transparent medium to feed the cells inside the eye, and that fluid has to be created, and then it has to be drained out. It has to have its own circulatory system, you might say. And that's where we get into what I call glaucoma plumbing. And that's easy to understand in the case of angle closure glaucoma, where there is blockage to the outflow of the fluid in the eye by the iris of the eye. The colored part of the eye is actually blocking the outflow. In open angle glaucoma, which is more common in European peoples, there's no blockage that we can detect. And the important difference there is this can be treated much better because we just have to get the iris out of the way so the fluid can get out of the eye. So we'll talk about that. if you cut an eye in half, you see the fluid is produced here in the ciliary body. This is the lens, this is the cornea. The fluid goes out through the pupil, and then it drains over here in what's called the trabecular meshwork. So in some people, the fluid itself pushes the iris forward. Here's the blue or the brown part of the eye, and that causes a blockage of the trabecular meshwork, just like a stopper on a drain, one of those old floppy stoppers you put on the kitchen sink. Well, that's what the iris is doing in some people. And that can be fixed by just punching a hole through the iris with a laser beam so the fluid gets through that hole and gets out of the eye. So these people are more commonly of Asian descent or are farsighted people. You sometimes can cure the disease. So what I said about not being curable really applies to open-angle glaucoma. If these people are caught early, you pretty much can cure the disease. The trouble is they're not usually caught early. Okay, how do we know if this process is going on? Well, interestingly, due to optical issues, you can't see in here by just looking in the front of the eye. You have to put a mirrored lens on the eye and look into that angle indirectly, and that's called gonioscopy. And this is a procedure we do on everybody who comes into the glaucoma clinic, but amazingly enough, it's not done in every ophthalmologist or optometrist's office. And they get paid for that. It's an additional charge, so that's a mystery to me. Here's another view of the anatomy of the eye. Here's the lens, the cornea, ciliary processes. So this arrow represents the fluid flow, and the fluid has to go out here. And this structure, the trabecular meshwork, connects to what's called Schlem's canal, which connects to the venous outflow of the eye. Okay, pressure. Pressure is measured in millimeters of mercury, and the normal range is 10 to 20. How does that compare to the air pressure that's around us at all times? The normal eye pressure is only 1 to 2% above atmospheric pressure. So the difference between the pressure in your eye and the surrounding air is very, very tiny. Yet if you go up to just 3% above atmospheric, you're going to get damage, probably in years. And you get up to this level, 5%, 6%, the eye is going to be destroyed by glaucoma fairly quickly, probably in days. On the other hand, if you go scuba diving to 32 feet, the pressure on your eye will go up to 2 atmospheres, or 100% higher, and you get no damage. There's never been any study shown that scuba diving causes glaucoma, amazingly enough. How can that be? Somehow the body knows that, in this case, the pressure is not a problem. In these cases it is. You know, certain fishes can go down to, thousands of feet of depth, dolphins or whales or something, and it doesn't affect their eyes at all. And yet these tiny percentages of pressure increase in the glaucoma patient are very dangerous. It's one of the many mysteries of physiology. I don't understand it. In fact, I've asked scuba diving experts why that is, and they don't know. Nobody knows. Okay, we talked about this. You have to lower pressure with drops, pills, lasers, or surgery. Here we go again. Most people start with drops, some people go on to laser, and I won't be able to talk about all these things because we don't have enough time. So what we're going to show is a little bit about surgery. The most common type of surgery in glaucoma, and this has been around for many years, is called a trabeculectomy operation. And what we do is actually create a safety valve on the eyeball out of its own tissue. So underneath this bubble, there is a little flap of sclera, which acts like a trap door, and underneath that trap door, there's a hole into the eye. So the fluid can leak out through that trap door and create this bubble. So the pressure builds up, a little fluid leaks out, gets into that bubble, and then it's reabsorbed by the venous circulation and relieves the pressure on the eye. This operation's been around for at least 30 to 40 years. It's very old, but it's still the best operation we have for getting pressure down to the 10 range or lower, which we need in some people. But it has a lot of risks. One of the major risks of this operation is you have to walk around with this bubble on your eye for life. What happens if this starts to leak? Then bacteria can go right into the eye, cause a bad infection, and you can lose the eye in 24 hours. So that we have a great fear in these people about infection, and we tell them, look, if your eye gets red, painful and blurry, don't call for an appointment, just walk in. If it's a night or weekend, you go to Tampa General and get it checked. And I tell that to my patients all the time. Now, when we can't do a trabeculectomy, we have alternative operations, and there are various reasons we can't do that in some people, where we put a plastic tube in the eye. So the fluid drains out through that tube, and then to give that fluid a place to go, we use plated devices that create a dead space under the conjunctiva, so the fluid goes out through that tube under this patch graft into a dead space which is maintained by this plate. And this is so-called an Ahmed valve implant because there's actually a true valve mechanism here to control the fluid flow out of the eye. And this is the most common type of tube shunt or valve implant used throughout the world in glaucoma because it gives you a reliable pressure, not too high, not too low. The problem is, over the years, scar tissue can come in and surround this plate and cause it to stop working. Second problem is, even when it works, you usually do not get pressure as low as you do as with a trabeculectomy operation. But there's surgical indications to do this, and we use them a lot. This is an eye that has a tube shunt, you see up here, coming in from above. And this eye has had previous laser iridotomies. Remember I talked about doing a laser to allow the flow from the back to the front of the eye. So this eye has two holes in it, in the iris, to allow flow from the back to the front. And you can see where the pupil is. It looks like the pupil is glued down to the lens of the eye. So this is an eye that's had what we call uveitis, where there's inflammation in the eye to the extent that the iris is sticking down to the lens, so the fluid can't get out, it's getting stuck back here. So the patient had laser iridotomies to try to allow the fluid to get out. And even as the fluid got to the front of the eye, there was still pressure, so the patient had to have a tube shunt put in. And these are the steps in the treatment of uveitis. Who gets uveitis? Syphilis, herpes zoster, sarcoidosis. There's a big long list of diseases that cause so-called uveitis, inflammation in the eye. Okay, to finish up, we will jump to the other end of the spectrum. Since this is my other activity, is to do astronomy research. This is the closest galaxy to the Earth, and it looks exactly like the Milky Way, and we sit about right here, about halfway out from the center of the Milky Way to the border. And so I think we're going to collide with this galaxy in about 100 million years or something. So make sure your life insurance is paid up. This is the Crab Nebula, which is in our galaxy. Let's see, if we were sitting here, right here, the Crab Nebula is out here a little bit, fairly close. This is an exploded star that exploded in the year, I think, 1051 or something like that, shortly before the Battle of Hastings. Was observed by the Chinese. It was not observed by Europeans because they were too busy killing each other in religious wars. And this is a very famous structure called the Crab Nebula. In fact, it's #1 in the catalog compiled by a French astronomer called Charles Messier back in like 1790. It's the #1 nebula in his catalog, so it's called M1. And up until the latter part of the 20th century, nobody knew where the energy was coming from that kept this nebula glowing. And in the late 60s, it was discovered that in the middle of that nebula is a star which turns on and off. So this is a photo of that star turned off, and 3 milliseconds later, it turns on. And 3 milliseconds after that, it turns off. And that was shown to be a spinning star that's spinning 33 times per second. And as it spins, its magnetic field sweeps through the gas and creates the energy that energizes that nebula. And this is where I do astronomy research in Puerto Rico. This is the so-called Arecibo radio telescope. This is 1,000 feet across. This structure that holds the antennas suspended by cables weighs the same as the Statue of Liberty. So the signals from space come down here, they're reflected up here, and they go down cables to the control room, which is somewhere over here, I guess. And that's where we're able to study objects like this. And that's a nice break from dealing with glaucoma, which gets discouraging sometimes. Thank you very much. Any questions?